Symptoms. None may have lethargy, vomiting, or poor feeding in congenital adrenal hyperplasia. Signs. Penile phallic structure, small, underdeveloped with hypospadias or very enlarged clitoral appearing structure. Scrotum labia, scrotalized, rug-gated, fused labia or cleft scrotum. Testicular or gonadal structure in scrotal sac or cryptorchid. Investigations. Ultrasound imaging of internal genital ducts, the absence of uterus indicates the presence of testicular tissue and Müllerian inhibiting hormone. Chromosome analysis to document genotype. Serum concentrations to document genotype. Serum concentrations of corticotropin, 17-OH progesterone, testosterone, androstenedione, to evaluate for the various forms of congenital adrenal hyperplasia. Vaginogram contrast radiographic study of urethra vaginal vault. Complications. Shock or death in patients with congenital adrenal hyperplasia. Poor phallic growth at puberty in patients with partial androgen insensitivity. Infertility. Treatment. Lifestyle. Psychological counseling for parents for reassurance of gender of child. Pharmacologic treatment. Pharmacology treatment is only necessary for infants with ambiguous genitalia with congenital adrenal hyperplasia. See adrenal hyperplasia. Congenital. The impotent treatment for children with ambiguous genitals is appropriate surgical correction, i.e., fixing the genitals for appropriate gender. For newborn or infant in shock, administer hydrocortisone, 25 to 50 mg IV every 4 to 6 h. The most important aspect of resuscitation is replacement of fluids and sodium. Often the infant will need 2 to 3 times the usual maintenance of normal saline during the first 24 h. Occasionally, the patient may require hypertonic saline. Generally no treatment is required for the hyperkalemia. Standard dosage for pharmacologic maintenance treatment, hydrocortisone. 10 to 15 mg/m2 divided in 3 doses daily. 9. Fluorohydrocortisone, 0.05 to 0.3 mg as necessary. Based on renin level. Late onset or non-classic congenital adrenal hyperplasia in adolescents, 0.5 mg dexamethasone or 5 mg prednisone each night. Contraindications none, but it is important to recognize that the usual practice of discontinuing glucocorticoids with varicella and other such illnesses does not pertain to the adrenal insufficient patient. Special points during acute illness, 50 mg per square meter divided in 3 doses. For several days as necessary. Major drug interactions none. Side effects. Chronic overtreatment will retard growth and result in short stature. Treatment aims to correct ambiguous genitals to best support sexual function as adult, to maintain ability for fertility if possible. Prognosis excellent in general. Children with congenital adrenal hyperplasia. Risk for adrenal crisis. Cases of gender reversal, risk for psychosocial maladjustment. Follow-up and management. See adrenal hyperplasia, congenital. Evaluate psychosocial adjustment. Evaluate gonadal function as child approaches teenage years. Evaluate genital surgical correction for sufficiency for sexual function. Other treatments. Surgical correction needed, genitoplasty.